Hi, how are y'all doing? My name is Jay Huang. I'm a fourth year pathology resident in the States. I plan to do general pathology. I go over cases almost on the daily from any organ system. If you like this, please give a like and subscribe. Without further ado, thank you to Pathlibrary for this slide. So the clinical information is this is a bullseye on the abdomen of a 65-year-old female. Separate perilesional biopsy submitted in Michelle's solution is available for ancillary studies. So basically, they're suspecting some bullous disorder, right? Because they submitted it in Michelle's solution, and that's to help with direct immunofluorescence. It's important to know that bullous disorders, the differentials, include like massive spongiosis, arthropod bite, herpes, as well as acantholytic dyskeratotic disorders like Haley-Haley, Darrier, Grover's, can also cause kind of like bullite formation. So it's just important to keep that in mind. So we have a split here, right? So when you have a split, you want to, your follow-up questions should definitely be where is the level of the split? So if it's in the dermal-epidermal junction right here, as we see here, then that suggests that there's an issue with the hemidesmosomes. If there's an issue with the keratinocytes, that's an issue most likely with desmosomes. So here we see a subepidermal split, and then the second question you want to ask yourself is what other cells present, and they're eos. They're not neutrophils. So that makes dermatitis herpetiformis and linear IgA less likely. So this is most likely Bullous Pemphigoid. And if you do a direct immunofluorescence, then IgG and C3 should be linear along the DEJ. Now, something that's similar to that is epidermal lysis bullosa acquisita. And to differentiate that, on immunofluorescence, you do a salt skin split. So what that does is after applying salt solution, it's gonna the findings are going to be the DEJ, or the linear immunofluorescence will be on the roof of the blister for Bullous Pemphigoid, and it'll be on the floor for EBA. Okay, so that's how you differentiate the linear or immunofluorescence findings of Bullous Pemphigoid and EBA. Bullous Pemphigoid to the roof and EBA to the floor. So let's see, anything else that we want to talk about? You can get dermal edema as well in Bullous Pemphigoid, and in the pre-bullous stage, the early stage, or the so-called urticarial phase, there are eos and dermal edema without a split at the DEJ, and I find these very difficult, especially during those early stages. Your differentials include EBA, and we talked about how to differentiate that. Porphyria cutanea tarda. This shows a split at the DEJ. Rigid dermal papillae protrude into the bulli, and this is known as festooning. There are usually PAS positive eosinophilic epidermal globules, known as like caterpillar globules sometimes. And then pemphigus vulgaris. And pemphigus vulgaris, you'll have tombstoning because it's a suprabasilar acantholytic blister. So your basal epidermal layer is intact. So I hope that was helpful, and I will see you next time. Bye.